Okay, and I will put the recording on the WhatsApp after it's completed. So I'm sharing this document. It just gives you a title, right? Decreasing sepsis in the NICU. That's your overall goal, correct?
Yeah.
And you're going to do it by making a change in the way you keep the incubators and clean the incubators. You're going to move babies more frequently than 20 days to 10 days. So that sounds good, but do you know? Can you give me a little background in terms of what is currently happening in terms of first sepsis rates and what's your policy for incubator cleaning?
Sepsis rate, we have already started collecting data.
Yeah.
It's around 36%.
36%?
Yeah. It's out of 50. Out of 25 case sheet we managed to retrieve.
Okay, so that's interesting because that's a high number. I think I just want to clarify whether these are actual suspected sepsis or confirmed sepsis.
It's all confirmed sepsis by blood culture.
Blood culture positive. Okay.
Yeah, blood culture positive.
Okay, so these are what you classifying these as sepsis, or you do you have a definition for CLABSI, like catheter-related bloodstream infection or unrelated or related? Is it including both?
Yeah, it's including
related and unrelated.
Yes.
Okay. And these are blood culture positive.
Yes.
So you said it was 36%. Okay. And this is for all NICU babies or only for like premature or any baby that's admitted to the NICU?
It's all babies admitted to our NICU.
All admissions. Okay. All right. So that's high number, I should say. So and also based on this, you said that maybe the change of incubators is important. Why did you come to that conclusion? What was going on that made you decide the incubator change as the main thing?
First of all, following your teaching, so we realized that 20 days was a bit too much, too long to cleanse our incubators, and that could be a source of infection.
Okay.
We didn't have it. Yeah.
All right. So 20 days. There are two parts to this, right? So one is the duration of time the baby's in the incubator, which is 20 days. But also, when you change the incubator, what is your procedure? Like, do you take the baby and put the baby on the warmer until the incubator is clean, or you have a clean incubator in which the baby goes from the other incubator to the clean incubator?
So we have a clean incubator, so we transfer the baby into a clean incubator. So the one we wash is going to be kept aside. Okay.
And then the one that's washed will go through the cleaning. One that's the old one will go through a cleaning process.
Yes.
And be ready for the next change, correct?
Correct.
Okay. So the reason I'm going into the details is that process is important. So did you do a process chart in terms of figuring out at what part of the process would infection be the most likely? So there's one part that the baby is staying in the incubator, where the infection is happening there, or the incubator is already contaminated before, it was not properly cleaned. And so when the baby gets into the incubator, the baby takes the infection. So have you gone through the process of the cleaning, the intermediate process, to see which way you may be? Because it may be that the time may not be important, but the incubator that the baby is going into is not totally cleaned.
We have clear protocols how to clean the incubators.
Okay. So this is the protocol from the company, like you have Giraffe?
Not really. We have it from our IPC, IPC team.
So the IPC team has a protocol and you're following the protocol. So you believe that the incubator is clean when the baby goes into it. and then
Yes.
somehow the baby develops contamination of the incubator. And the longer the baby stays in the incubator, the more contamination. So that's why you're going for a shorter course in the incubator. Is that correct?
Yeah, that's correct.
Okay. So what I would suggest is, so let me go through the process of so I'll send you this document which I've created as a Word file, and you can fill in the blanks. So the next part is the background, like what protocols actually exist for the in-between period. You already have a protocol you said, because there are protocols related to disinfection, drying, terminal cleaning, change of filters, and how long the baby should be in the incubator. So these are all protocols available, and there are hyperlinks there. You can go and check. And then the next question was, where does the baby go during cleaning? The baby goes to the other incubator. Some places they put them on the warmer, clean, and then put the baby back in the same incubator. But that's so your process needs to be clearly outlined in a process chart. You know, the process chart, we talked about it.
Yes.
You take all the steps and make sure you have all the steps lined, and just put that process chart in your file. So I've created a place where you put the process chart, put it there in this particular file. Okay. And whether the question in cleaning frequency alter infection risk, there's some data on it. There was one study that showed a decrease. So what you're doing seems like a good plan, and I will send you that paper that you can refer to, what they have done. And this also seems to be a difference between developed and developing countries in terms of contamination risk. So I don't know where Mauritius comes in, but they may be, especially with humidity and environment and all that, that makes a difference. So with this, I wanted you to kind of fill out what is the current status at Victoria Hospital in terms of sepsis rates, whether it's catheter-related, non-catheter-related, other sepsis, UTI, meningitis, pneumonia, NEC. What is the different breakdown? Because you also want to see the pattern. You know, environmental contamination presents a different way than IV contamination versus air contamination. So you may want to break it down so you can follow if the pattern is also changing when you change your policy. So make sure you classify whatever sepsis rates you have, you see if you can categorize them into these. It may be that most of them are other sepsis, some are catheter related, some are UTI, I don't know. You can fill this out. So that's your background. And so once you've done the background, then you go to your SMART aim. So what is your SMART aim? I'll type it in while you're saying
it. So to start with S, so it's specific. So it's how to say, we have a specific goal, like changing incubators.
No, your specific goal is to decrease your sepsis rate.
Yeah.
Yeah. So I will say decrease rate of sepsis from 36%, which is currently what you're saying is your rate.
Yes.
To how much? You want to go by how many
15.
percent?
To 15.
To 15%? That's a 50% reduction. Okay.
Yeah.
To 15%. Okay.
Okay.
And so that's the specific part. So it's measurable. So how are you going to measure it? What's your measure? So you're basically basing it on bloodstream infection, culture positive.
Yeah, that's true. Culture positive.
Based on blood culture positive results. Okay. And achievable and relevant. So basically it's achievable. How quickly do you think you can do this? This 15% reduction, 1 month, 2 months, 4 months, 6 months?
I think it's going to be over a period of 4 months.
Okay, so over 4 months. Okay. So decrease infection rate from 36 to 15% based on positive blood culture results. The other thing which is you need to know is for all NICU admissions, right? This is not just for premature babies. Correct? For all NICU admissions over 4 months, and of course it's relevant because it'll help you. And then timely, you said 4 months. So basically, I think that would meet your SMART goal requirement. So decreased rate of sepsis 36 to 15 based on positive blood culture for all admissions over 4 months. So that's your goal. How you achieve the goal is going to be with the change in your policy of incubator. All right, so that's your SMART aim. Now, the primary driver for this that you're saying is going to be decreased contamination by changing the incubators, right?
Right.
Every 10 days instead of every 20 days. Correct? Does that make sense?
Yes.
Okay. So that's your primary driver. I mean, this is talking in the language of QI. You need to have a primary driver. That's the main thing that you think will impact your aim. That's the driver of your to achieve your aim. So to do that, how are you going to do this primary driver? You have to have methods by which you can achieve this change in incubator. So currently, the change is dictated by what? Is it by policy or is it by how the incubator looks in terms of dirty or clean? Is it based on the nursing impression? What is it currently based on? The 20-day average that you have? Is it just a fixed 20 days, or that the incubator looks clean or not, or does it differ?
Usually like visually it looks dirty, so it's around 20 days. So around 20 days, we all feel that we need to change the incubators.
But that's what I'm saying. So some babies may dirty the incubator more frequently. He might have peed on it. So I'm just asking because you need to have this all clearly defined. In that case, would you still wait 20 days or would you change it earlier?
We would change it earlier.
Okay. So currently the policy of 20 days is not fixed. It is average, kind of most likely.
Yes.
But in some cases, you may change it earlier. In some cases, do you go later? If it looks very clean, do you go more than 20 days also?
Yeah, we can go more than 20 days sometimes.
So currently you have general rule is 20 days, but it could be earlier or later. So you need to, in the secondary drivers, you need to have, whatever your current policy is, you need to clearly define. So and see how that can be changed. So currently change occurs by how it looks, baby contamination. Maybe it also depends on how much time people have, how busy the unit is.
Yeah.
So you need to kind of go through the secondary drivers and see how you can, what are the different things that you need to take into account to achieve that change. So you may want to, as a group, as your QI team meet and see what are the different things that make you change. The nurses will know so you need the people in the team to really kind of discuss it out and see what you want to write down as what your old policy is, make a note of what you're currently doing, and then see what your new policy is going to be and how you're going to make it happen? How are you going to implement it? Who's going to make the decision? Or is it going to be based on just the number of days or a checklist or whatever? You need to come up with a plan. And that's going to be a secondary driver, which will impact your primary driver, which will impact your aim. You understand the process?
Yes.
Okay. So I'm just giving some kind of an indication. You might have to fill this out. I'll send you this file. Okay. So the next is who's the team? The team is very important. Based on what you want to achieve, you need to have a full team, and you need to have people's names listed. So the team leader, I think it's best to be a doctor and nurse who's actually working in the unit, not the chief medical officer or the administrator, because they don't have time for this. And then I think it's good to have a co-leader. So if doctor is the leader, the nurse is the co-leader, or the nurse is the leader, the doctor should be the co-leader. So there should be two people, one from each kind of side. And then other people, other doctor members, other nurses members, you need to list them out, because the team needs to know who's on the team and who's not on the team. So you can include as many people as is interested. You don't have to include every single person, because every single person may not have the time, but you can have 10, 15 people if you want. So at least 6, 7 people should be there, minimum. Maximum, you can do whatever. So, and the other members on the team should also be there. But for example, people who actually clean the incubator, is it done by nurses or some special person?
Yes, nurses and healthcare.
Okay, so they need to be part of the team also. Whoever's cleaning, whoever's ordering the disinfection supplies, or whatever the IPC member that dictates how your policy works, they should be there. Hospital administrator should know that you're doing this, because you may need some special cleaning solutions that you don't have, and they have to support you. You're a biomedical engineer for the incubator. I don't know if you have a biomedical engineer. They should be all part of the team. At least if they don't come to the meetings, fine, but they should be informed of what's going on. So that should be the team. So now you have your aim, your primary drivers, secondary drivers, and your team. So far, so good?
Good.
Questions from what I've just said so far? Any other members of the team? I mean, everybody can talk. There's no problem.
Dr. Hussain, for extreme preterm on humidity, we usually put 80% in the beginning, and only at the end of 14 days we change the incubator.
Okay, so that's interesting, because when I was doing some background work on this topic, I came across this. Humidity, water management, use sterile water. I don't know if you do that. Avoid prolonged high humidity beyond what is clinically necessary. And clinically necessary, most babies keratinize their skin by about 5 to 7 days. So the longer you keep the humidity, the more the chance of infection. So you can do some background literature. I've got some hyperlinks here, but I think that 2 weeks is too long. But again, you do whatever your team considers to be the appropriate for your situation. But I think the literature supports that 2 weeks is too long, especially in a country that has already got a high environmental humidity.
Okay.
Yeah, you're a tropical place, so your humidity is probably already high. So you don't need the higher humidity. 80%, we do it for like maybe 1 to 2 days in our unit, and then start coming down. But again, every place is different. You need to make your own policy based on what you find. Okay, so going back to, so any other questions before we move to the next item?
Concerning our outcome, it's late onset sepsis. Some babies do have sepsis, like after 2 weeks or 3 weeks, or some after 3 days to 7 days. So what's our definition for late onset sepsis when we are doing this project?
I would say, that's a good question. I think we should have, in the definition of sepsis, you need to clearly define early and late onset sepsis. So here, when you said sepsis, different kinds of sepsis. So this is, I would say, late onset sepsis is what you should be focusing on, because incubator change should not be early onset sepsis. Should not be affected by incubator change. It is more environment. So early onset sepsis. So you need to kind of, in your definition also, SMART aim, I think you should focus on late onset sepsis. So decreased rate of late onset sepsis. And that is usually defined as more than 3 days after birth, or you can say 5 days.
Okay. So, and there's no time frame like 3 weeks, 4 weeks?
No.
Okay.
You have to decide. I think I would say more than 5, keep it more than 5 days, just to be, that is, I think, universal. Some people use 3 days for late onset sepsis. So decreased rate of late onset sepsis. And again, you may have to change these numbers, because if you look at your current, you should exclude the early onset sepsis from this. So out of the 36%, if say 5% are early onset sepsis, take them out. Because you will not be able to impact early onset sepsis by incubator change, because that, it occurs much later. So that's a good question. You should be focused on late onset sepsis. So that's the importance of having a discussion, because if one person is doing it, they don't think of everything. But if there's a group sitting down, somebody will think of all these questions, and then your study will be more compact, will be more focused. Okay, any other questions?
No.
All right, any other team members? You can even chat. I've got my chat open, so if you want to chat, that's also fine. All right, so I'll move to the next item that you have to do in your first PDSA cycle. You first have to plan. So basically, you got your primary outcome. You're going to look at sepsis rate as your primary outcome. And your secondary outcome is going to be, what kind of sepsis, whether it's NEC, pneumonia, whatever, you can do the secondary outcome. So that is very clear. You got to do this, but also you need to have some measures of your. So how are you going to measure it? How are you going to measure your sepsis rates? Currently, you basically look through the charts and you said, this baby has sepsis, this baby does not have sepsis. So you need to do the same thing going forward, but you need to have a clear idea of how you're going to measure it. So you need to create a form. So baby's name, whether the baby had sepsis, yes, no. What kind of sepsis the baby had, was UTI, bloodstream infection, pneumonia, NEC, meningitis, whatever. Then maybe need to know what kind of organism that baby had in the blood culture. And then anything else that you are following, day of life, the sepsis occurred, whether it occurred in the first week of life, second week of life, fifth week of life, but anytime before discharge. So each baby should have some kind of a way to track this baby all the way from birth to discharge in terms of the sepsis. And some baby may have 1 episode, some baby may have 2 episodes, some baby may have more than 2 episodes. So create a form in which each baby should be on 1 row, and each column should be for different things all the way till discharge or death. Okay, so you need to create a form for this primary measure, and the same for secondary measure. I think you can look in the primary measure form and you can come up with the same information. So that's fine. But the process measure is also you need to measure. So you need to kind of have an idea of, so baby, say baby X was there, how many times the baby had the incubator change from birth to discharge for that baby. So you need to have a column for incubator change number 1 and day of life when that was done. and incubator change number 2, day of life when that was done, and all the way until discharge or death. So you will know, you can correlate how many, whether this baby, first of all, were you following your protocol? You said you were going to change in 10 days, or when the incubator gets soiled, did you follow that protocol? Yes, no. So you need to put the date when the incubator was changed and whether the protocol was followed, yes, no, for each time that baby had. So that's your process measure. You can incorporate it in the same data collection form as your outcome measure. You can just create a separate column for incubator change. Do you understand what I'm saying? You need to track that, because otherwise you may have made the plan, but you may not have actually implemented it properly. Maybe the babies are still being changed 20 days. You don't know that. So if you don't know whether you didn't get the right outcome because you did not follow the process or really it did not work. So you need to have a measure of process. It's very important that you're following your process. Okay. Then the third thing is balancing measures. So now you have created a change. You're changing from less frequent to more frequent incubator change. It may have some negative consequences. Some of the things that I'm thinking of, that in the change, there may be more babies getting hypothermia because you're moving babies from one incubator to another. Or there may be babies intubated, they're trying to move, you got extubated because of that. Or the babies had an IV line, when you're trying to move, the IV line came out. Whatever. You need to create at least 3 or 4 balancing measures to say whether this change that you made is not having a negative effect on your babies. So think of all the negative effects that can happen when you change too frequently. Or maybe the cost is going up, or maybe the personnel time that you're doing. It's whatever you think is important for your unit. So at least 2 or 3 or 4 balancing measures. And then create a form in which you can track it. So for the same baby, how many episodes of hypothermia occurred during the change? How many episodes of unplanned extubation? So when the baby was being changed, was there unplanned extubation? Yes, no. And then you can, or when the baby was being changed, did the IV get dislodged? Yes, no. That kind of, again, keep track of it so you can, if somebody asks you, when you did this, did something bad happen? And you can say, no, we tracked all these things and nothing changed. Or you could say, you know, unfortunately, there was more increase in the IV dislodgement. We'll have to work on that the next time, whatever it is. So you get the idea what I'm saying? So you need these 3 measures.
Yes.
Yeah, so this, again, you fill them out in the form that I'm going to do, and make sure that you create a form for each one of them to collect. I don't know if you're seeing it properly, but I'll send you the list. So now you've done the plan, and then during the study that you did, you're creating all the forms. Then you need to do it over the 4-month period that you're saying. So you need to have people responsible for data collection. Okay. So data collection for outcomes, process measures, balancing measures. You need to have a system in your team to say who's going to collect the data. Is it going to be every day, or is it going to be at the time of change? When you're changing the incubator, you're going to collect it. Or you may want to do it, once a week. Just go in and see what happened. Whatever your team decides, you make a plan and make somebody responsible. So week 1, this doctor is responsible. Week 2, this doctor is responsible. Whatever, you make a plan. And so make sure that people are doing what they're supposed to be doing. And the team leaders should keep track of whether this is going on or not. Okay. And while you're doing it, you also, I think it's a good idea to what we call continue doing the study. So the best way to study while you're doing it is called a run chart. And I've shown you an example of a run chart. A run chart is basically each day or each week, whatever your unit of measurement is, you can say how many babies had incubator change at the 10-day period that you are planning to, and how many total babies were there that were eligible. So week 1, in that week, you had, say, 10 babies in your NICU, and 3 of them were eligible for a change because they had gone more than 10 days, but you changed it only on 2 babies. So you would say, you know, eligible number of babies were 3, actual babies change were 2. Or you could say eligible were 3, actual change were 3. So you're following your process on a run chart, week by week by week, to see how well you're doing in your plan. At the same time, in the same chart or another chart, you can create a run chart for sepsis rates. So you are that week, what was your rate of sepsis? You had 10 babies, 2 babies had sepsis, your rate was 20%. So keep a track of that week, your change of incubator and your sepsis rates, and do it every week all the way up to 4 months. So you can see on a graph what is happening. Is it going down? Is it going up? Because you don't want to be waiting 4 months to kind of make a change. If something is happening that's going bad, you want to know right away. Or if something is going good, then you can say, oh, you see, you know, we are actually making improvement already. So do a run chart and keep it somewhere where everybody can see on the unit. We have like a corkboard where we have the run chart, and every week, whoever is responsible for entering the data plots that out on that chart with a marker or pen or whatever. So use your run chart as some kind of communication thing for your team and other people to say, you know, you're doing this QI project and it's working well or not working well, you'll find out. So create a run chart, and that's part of your study. So when you finish your 4 months, you will do, I think, everything, but you will also, by that time, already have your data on a chart. You will see what's happening. Your rate was, you know, 30%, now it is 20%, or 15%, or 10%, or 45%. I don't. You can see what's going on. So that's something that would be part of this, and keep this all in a folder in your unit so everybody can see the plan and what you're doing. And then, of course, after 4 months, you're going to assess everything and see what happened. And then you will, again, do whether something you did was effective, you will continue doing it. You will adopt that. If it was a little change needs to be made, you'll adapt it. Or if you felt that it did not make a difference, you discard it. Okay. And then you create a next PDSA cycle based on your information. Now you're going to jump on. Now you've got to 15%, you want to get down to 10%. And what should be done next? So you go to the next cycle. Okay. So that's your form. And I think something like this hopefully will get you a jump start and get you going. So I'm going to use this file and I'll email it to you.
Okay.
So what are the other questions or other things you want to talk about?
We have a question here, Joseph.
Yeah.
We were wondering what if a baby got a recurrent sepsis. So how should we collect this data as a recurrent sepsis with different bugs? Like first week of life, the baby got a sepsis. Then on the 3rd week until discharge, like the baby has 2 or 3 episodes of sepsis.
All right. So what I would say is I think the form that you create will probably help you in that. So let me see. So let me show you on a whiteboard here. So can you see this that whiteboard that I've created?
Yes.
All right. So you have, sorry, I don't know what's happening. Sorry, I've got to clear this. So you have baby X here, and you have you could use that week 1, week 2 here. So sepsis, yes, no, okay, and then week 2, sepsis, yes, no. So the baby had sepsis, say yes. Then you would also enter the organism right next to it. Or you have another column where you say organism. So organism, and you would say whatever, staph or whatever. And then week 2, whatever organism there was. And if there was no sepsis, then you say no. And then do this all the way until discharge. And also in this same baby, you will have incubator change date, and that time the incubator change, what was the date, and again, whether the baby had any other negative consequences like IV dislodgement and all that. So for each baby, you'll have one column. All right, and that's something that you can do on like an Excel spreadsheet or just create a form, and then do it that way. So over this 4-month period, you will probably have, first month 10 babies, second month 20, 30, 40, maybe you'll have 50 babies by the end of 4 months. You'll have 50 lines, each baby 1 line, and all the way from week 1 to discharge or death. You can play around with it, and you can do different ways, but that's something that I think you may consider. Somebody may have a better idea to chart it. That's also fine, but try to keep all the information in one place so you can look at it. And if you are having difficulty with it, when you create that form, if you can create it on an Excel spreadsheet, just send it to me. I'll try to look at it and tweak it back and send it back to you.
Okay. So,
other issues, questions?
what? It's already anyone emergency. Exactly.
Right, it's just sent you the form as a Word file, and I'm going to send you a few documents.
We have a question in the chat.
Okay, let me see. Chat. Let me see. My chat is. Can you read it out? Because okay.
Yes. So we were just asking how frequently do we do a blood culture?
Oh, frequency of sending blood cultures? I don't know, whatever your current policy is. You don't have to send blood cultures. So let me tell you our policy for send blood cultures. We only do it when your baby is symptomatic and we're suspecting sepsis. Okay. We do not send routine blood cultures. So sometimes right at birth, we get the first blood culture because we're suspecting early onset sepsis. And after that, it's only based on whatever the baby is doing. So if you think the baby is having change in clinical signs, the baby is looking septic and all that, and usually corresponds with when we're starting antibiotics. So we usually do not start antibiotics until we get a culture, and then also when you do a culture and start antibiotics, we stop the antibiotics as soon as the culture comes back negative. So usually 36 hours for us. So if you see our babies, we rarely get cultures as a screening. Actually, we never get cultures as screening. It's only based on clinical. So your question is, it depends on how your baby is doing. If you're worried about the baby, you get your cultures. Other questions? So I have, yeah, go ahead.
I think we don't have any more questions.
So then now you have to tell me, I've sent you some of the things that I said. So I've sent you the Word file, and you can create your own document for your QI project based on that Word file. You can add more stuff to it and all that. I've sent you a few papers that I found relating to this question of incubator change and cleaning and all that. So also make sure your protocol for cleaning is clearly laid out, and also try to include that protocol into your document, and make sure that everybody's following that protocol also. So track everything.
Okay.
Yeah, and again, questions, you can just call or text me on this WhatsApp group. But also make sure that you meet regularly. So meet every 2 weeks as a team, or every 1 month as a team. So between now and the finishing of the protocol, you should meet at least 2 or 3 times, or more times. And I would say meet once before you finalize your document. And once you finalize your document, you need to educate everybody that you're doing this, and then set a target start date. So when you say the start date, that's when you start counting your 4 months. So right now, you may be doing whatever you're doing, continue doing that, but the actual target start date should be when everybody has the same protocol and everybody's aware in the unit that you're doing this protocol, and they should know, or put something that we are starting on like November 1st or December 1st or whatever date you have. So then you can start the count of your 4 months from that period. And anything you do before is background information. So you can collect the data, but use it as background. And the data after the start date would be your implementation results. Also, your results will be based on that. So if you start too early counting, then your results may be contaminated. So make sure your results are going to be clean. So start them only after everybody is doing what you're supposed to do.
Okay.
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 All right. So you've got a lot of things to do. You've got to create the process, all the data collection forms. You need to create the run chart and find a place in the unit where you can put out that information, including your smart aim. All right.
All right.
So good luck, and I think I'm quite excited. Let's see if we can make a difference in sepsis rates.
Okay, thank you very much for helping.
You're welcome. You're welcome. And all the stuff is on your side now, so the ball is in your court. All right. Take it.
Okay, thank you very much.
Take it easy, and happy belated Diwali to all of you.
Thank you very much.
Yeah. All right. Okay. Bye-bye. Got to sign off.
Bye-bye.
Yeah.
Bye-bye.